Very good. Very happy to be here today. Thank you so much for your interest in this topic. I am a breastfeeding medicine specialist. I got my IBCLC in the year 2000, and I've been doing breastfeeding medicine exclusively since 2001. And I started doing frenotomies shortly after we opened in 2001. So I've done a lot of them and followed the literature closely. So I'm very excited to share it with you today. I want to thank IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education, that has allowed me to use the slides today. A lot of these are from a presentation I give every January for our core content course, which is 5 days long, intended for uh, people who want to learn breastfeeding medicine basics. And it was great not to have to reinvent the wheel. So my objectives for today are to talk about anatomy of lingual, and we'll touch on labial or lip frenulums as well. Um, just be able to describe 4 symptoms of tongue tie, consequences for mother and infants both. Recognize our limitations in knowledge and a lot of the controversy that unfortunately is swirling around this issue. We'll discuss those as well. So I think you have to start with what is the tongue supposed to be doing while breastfeeding? So if we go to the baby diagram on the left, what the tongue is supposed to do is be able to reach out to grab the nipple areolar complex or some of the breast tissue, not just the nipple, to draw it into the mouth. It needs to be able to cup, like the baby in the center. The edges need to be able to rise to cup around the breast tissue to help hold it in place. And then it maintains this contact throughout the feeding so that the latch stays deep. And then something a lot of people don't think about is that the mid tongue, the middle of the tongue, needs to drop to provide a vacuum that then draws the milk into the mouth from the nipple. So if you haven't seen it before, I really urge you to Google breastfeeding ultrasound real-time 10 sucks, and you will get this video. And to orient you, if you choose to watch the video, this white line is the bottom of the nipple. This is the top of the nipple. This is the front edge of the nipple. This is the tongue. And unfortunately, you can never see the tip of the tongue because of the baby's chin, and ultrasound will not go through the bone. But you can see that the tongue is drawing the nipple back to the juncture of the soft and hard palate. And at this moment in the video, the tongue is dropping, the mid tongue is dropping, and the pores, ducts are opening up, and the milk is this white substance being drawn into the back of the baby's throat. And then they swallow and they do it all again. So the tongue needs to be able to move up and down to create this suction. What is the definition anatomically of a tongue tie? Well, we think it's a remnant from the formation of the tongue. The tongue forms embryologically from the form of the mouth and it from the floor of the mouth, and it's felt that this midline piece of tissue is a remnant of that. It's left over. It doesn't always dissolve all the way. We do not have good data on what the incidence of frenulums are under the tongue because there's not a clear definition of what constitutes a countable frenulum. So depending on whether you're only counting the ones that attach way to the tip, it's a fairly small percentage, but if you count all of them, it's a fairly high percentage. And it probably depends on your patient population. That really hasn't been studied. But there is definitely a male predominance in the classic, very toward the tip of the tongue type of ties, 2 to 3 to 1. And the studies have been done. It's more common for boys to have a tie that attaches way to the tip of the tongue. And there definitely appears to be some genetics involved in some families. It's common to have them occur over and over, but they don't have to be occurring over and over in a family. There can just be one. What is it made of? Interestingly, no one really looked at this until 2019. We finally have a really nice study where this is a cadaver, and number one is pointing to where the mucosal fold is attaching to the floor of the tongue. So the tongue's here, the jaw and teeth you can see are out here. So they've lifted the tongue up, and the most all frenulums are made of a fold in this mucosa in the floor of the mouth. So it's folded up and stuck to itself and attaches somewhere under the tongue. Then there's varying degrees of involvement of the fascia, the more like if you're cutting through a chicken or a steak, the white fibrous substance is the fascia surrounding muscle. And many frenulums have a fold of fascia as well. And the insertion of that is number two. So the mucosa is thinner, it's kind of see-through in life. Um, and then the fascia is much thicker and doesn't let light through. So this was a breakthrough in our understanding because a lot of people before talked about how there was this strand underneath the mucosa and you just had to clip the strand. That is not actually true. What is actually true is that small subset of people don't have any frenulum at all, and it's just mucosa over fascia. The mucosa is colored red in this diagram, and the fascia is green. In a lot of frenulums, the mucosa is the only thing involved. So very thin see-through tissue is folded on itself, and none of the fascia extends out into the frenulum. Many times, though, there is a varying degree of fascia coming out into the frenulum. So it can be just a little bit, it can be all the way. And some of you may be having an aha moment that when you see a frenulum that's only part way clipped, it's often because the practitioner is stopping at the see-through skinny portion because they're scared of the thicker portion farther back. So this can be just a small amount, or it can come out all the way as far as the mucosa does. And then rarely, I've seen this once in 25 years, you can have part of the muscle extending into the frenulum, and that's very obvious. It's extremely thick when that's the case. All right, so I'm going to propose that you consider watching your language surrounding tongue tie. So I am guilty as well that we talk about the frenulum being a tongue tie, but I think it's more helpful to try not to say a tongue is tied unless you've proven that it is not functioning normally, that there has been an impairment of function. So if there is an impairment of function, then it's tied down. But if it's just a structure that's present, then it is a lingual frenulum. So an anatomic description is that yes, there is a frenulum there, but a functional description would be ankyloglossia, which is just Latin for tied down tongue, or tongue tie in English. What are the classifications of a tie? Most medical professionals use the Carillus typing system, where type 1 is where the frenulum itself attaches to somewhere between the tip to 25% of the way back on the tongue. So this is a very tight, thick, looks like there's definitely fascia involved in this one. It's not stretching at all and it's see-through. It's a really significant one there. Type 2 attaches somewhere between 25% of the way back on the tongue and 50% of the way back when you extend the tongue. So typing's tricky depending on whether the infant is pulling their tongue back or sticking their tongue forward, and it can be difficult to decide, especially a 2 from a 3. But a 3 is supposed to be halfway to 3/4 of the way back in its attachment, and a type 4 is very far back, the last 25% of the floor of the mouth to the base of the tongue. So the typing system is really mostly useful for research purposes and talking amongst yourself as lactation professionals about how significant the anatomy of this tongue tie appears. There are some objective tools to use when trying to decide, is this tongue tie a problem? Is this, ooh, I did it. Is this lingual frenulum a problem? Is it a tie or is it just a frenulum? And I've highlighted the one that I think is most useful. The other ones are much more involved than the tabby, which was developed in Bristol, England. And this is it. You just look at what is the appearance of the tongue, the tip, where does the frenulum attach? Front, middle, back. Where does it attach at the gum line? Front, farther back, way back. how high can the baby lift their tongue when they're crying? And does it reach the middle of the open mouth? And if none of it does, then you don't get any points. If just the outside can, but the middle can't, then you get 1 point. And if the whole tongue can lift, then you get 2 points. How far can the baby extend it? Not past the lower gum, just past the lower gum, but not past the lower lip or way past the lower lip. So when they developed this tool and looked at, it was a group of ENT surgeons working with some lactation people, and they found that anyone who scored less than 4, it was decided that it was a functional problem and they got clipped. So anyone less than 4 would be all these people, and actually all these people, because if you got 1, 2, 3, 4 points, you still ended up getting clipped. Most of those who got 5 points, 2/3 who got 6 points, 1/3 who got 7, but the babies that were totally over here, none of them ended up getting clipped. So it's a tool that can be useful, especially if you're just getting started assessing tongue ties, trying to help decide if there's a functional impairment or not, just visually. What about literature reviews? What studies have we had about the usefulness of clipping the tongue ties, and what have they found? One of the two most recent ones from February of 2022 looked at 6 trials that they felt were rigorous enough to include. 4 were randomized as to who got the clipping and who didn't. 2 were not. And then they did an analysis of all of them together and decided that doing the frenotomy would help increase breastfeeding difficulty scores in 4 of the studies. And similarly, many studies of those studies showed a statistically significant difference in improving pain. So one of the earliest things that was looked at, and one of the things that's been shown over and over and over, is if you cannot fix maternal pain and there is documented or visualized poor function, then it's reasonable to consider clipping if there's no other reason for the pain, which is the tricky part. So their conclusion was these results support that frenotomy is effective for improving scores on breastfeeding difficulty and maternal pain scales, which might improve breastfeeding outcomes. So one of the really big criticisms of all the research we have is we don't have any long-term 2-month, 4-month, 6-month, year data on how a frenotomy affects long-term breastfeeding success. It just hasn't been done. This meta-analysis or systemic review, both, I thought was worth noting that in their conclusion, they say current views of ankyloglossia management leave considerable room for interpretation and variation in practice, leading many mothers to feel frustrated with providers' conflicting advice and care that is not always aligned with their goals for feeding their infant, which is not something you usually expect to hear a rant like that at the conclusion of a meta-analysis of a bunch of scientific studies. But I think the authors were also reflecting, their frustration that there aren't really great, clear answers to a lot of our questions. But they were able to conclude that ankyloglossia is adversely associated with breastfeeding success and maternal well-being when you're looking at immediate self-efficacy scores, not long-term success, because we don't know that. And I wanted to show this because it's one of the few studies that actually took the time and effort to look at the different typings. Remember, 1 is way to the tip, 4 is way in the back. How many of the frenotomies they did had the different types, and somewhat about the symptoms that the babies had. But first, let's look at 100% of the babies who had it all the way to the tip or almost all the way to the tip ended up getting clipped. And this was in a breastfeeding center with pediatric surgeons in Turkey doing the procedure. Type 2s, most of them got clipped, 73%, but not all of them. Type 3s, surprisingly to me, it was only 9% of the type 3s they decided needed to be clipped. But half of the type 4s. But you'll notice that the type 3s were 71% of the total, which I have never, and we don't have data on if you just look at babies in the nursery, what kind of frenulums do they have? That would not be hard to do, but nobody's really done that. Um, in my population, which is only people having trouble with breastfeeding, I would agree that I see a lot of type threes. I just never really thought about, is that the actual most common type or not? And maybe it is, but again, I only see people who have trouble. These guys were also, oh, actually, I'm sorry. These guys were following 705 births over prospectively over time, which is also kind of unusual about this study. And they found that 33% of their babies had some kind of a frenulum. And they followed everybody for 3 months and watched how many of them ended up getting clipped based on presumed need for it. But I will point out that culture, that looks like they're used to clipping them much sooner. The type ones were mostly clipped in the first week. Twos, threes, and fours were more likely in the second week. I would say here in the United States, we often are waiting longer than that. Um, the symptoms they saw with a type 1, the babies were much more likely to have trouble grabbing the breast and holding on, which makes sense. All the types were accused of having poor latch and or biting and or nipples slipping out of their mouth and or frequent feedings, and only type 4 was associated with weight loss, but I would argue that's because they clipped them all in the first week or two. So the fours were ones that weren't causing pain, presumably, but then they weren't gaining well and they ended up clipping them later. So that is one point I would like to make today, is that when you have a frenulum, posterior frenulum, which there's not a good definition for, but in my mind is a 3 and a 4. If it's farther back, it may not, it can cause pain, but it may not. It may be more likely to cause trouble with that lift and therefore suction creation. Therefore, it can take a little longer for you to see that if mom's milk production is generous. All right. Wanted to mention this ENT clinical consensus statement, which is kind of hilarious because it's not really a clinical consensus statement. They came together in 2020 and said, gee, there's a lot of frenotomy happening. It seems like we ENTs should have a statement about it. And they tried to come to agreement on what to say, and they really couldn't. So they decided to just publish the results of their survey about the questions they wanted to answer. So I just pulled it's really an interesting read to look at all of it, but I just pulled some of the most germane ones that they really agreed upon. So yes, it can cause tongue restriction. Yes, babies are being overdiagnosed in some communities. Yes, people are having babies' tongues clipped and lasered unnecessarily in some communities. Um, you have to do a careful lactation history and examination before you decide to do a frenotomy, and ideally someone with lactation credentials should try and help the mother first before you come at them with a procedure. And then they also point out that there are other reasons for breastfeeding difficulty that should be ruled out. Again, important to see someone who knows how to assess those things. And then they went on to agree that relative contraindications for performing a frenotomy include but are not limited to a really recessed chin, a really small chin, which can make latch really difficult on its own, and you can happen to have a tongue tie at the same time, and which thing is it? Neuromuscular disorders, where if you have low muscle tone for any reason or your muscles aren't working right, then that's going to make it harder to breastfeed on its own. And certainly if you can't clot after the procedure, you really should think twice about doing that. And any informed consent before the procedure should include mentioning that we can't promise that this is going to help your breastfeeding difficulties. And I think that's really important, that it's a procedure to be done if everything else has been tried and is not working, and there's reason to believe that the procedure will be helpful, then you would offer to do it, but it's not guaranteed to be a fix. The American Academy of Pediatrics finally last year came out with a statement about tongue tie. And I bolded kind of what I felt was one of their synopsis: symptomatic ankylosing, so causing trouble tied down tongues is defined as a restrictive frenulum that causes trouble with breastfeeding that are not improved with lactation support. Infants with ankyloglossia, normal feeding patterns need no intervention. So if it looks like the tongue maybe is tied down a little, but the baby is able to eat without pain and get plenty of milk, then there's no need to do anything. Frenotomy for other problems or to prevent issues such as speech later in life or obstructive sleep apnea sometime in the future is not evidence-based. So we're going to talk about that teeny bit more in a later slide, but they are saying only do frenotomy if the baby's having trouble with breastfeeding and everything else you have tried is not helping. And they suggest this algorithm, which I've shared, which is pretty good. So if you suspect a baby's having trouble with a tongue tie, they put in big letters that you should go to the medical home. So go to the pediatrician or the family medicine practitioner who is caring for the baby. Don't go straight to the dentist. So this whole paper is really kind of pointed at the frustration of parents going straight to a dentist or from a lactation consultant to a dentist to have their tongue and maybe lip frenulums revised, burned away, and then the primary care provider had no say in the matter, and they're frustrated by that. So they say you really ought to start with the baby's primary care provider, and that's good as long as the provider has either themselves or someone they're working with who knows how to evaluate a feeding and make suggestions to improve breastfeeding. Um, then if the person who knows how to assess that says, yes, there's problems with tongue movement affecting breastfeeding negatively, then they say go to a billable provider, which is another dig at dentists because often dentists take cash only and not insurance, and avoid costly non-evidence-based treatments like craniosacral therapy. So there's a whole recognition of the fact that there's lots of reasons babies can't breastfeed, and oftentimes they're neuromuscular related, and it can be helpful to have others on your team, um, such as speech pathologists and OTs, to evaluate any asymmetry or muscle weakness and that sort of thing. But in a lot of places, there aren't people with good experience with breastfeeding babies. They learn about bottle feeding babies. They don't really learn about breastfeeding. And so a lot of people reach for local craniosacral therapists. And I actually have one who's a physical therapist in Omaha that I refer my babies to, that I'm not sure if it's a tongue issue or a nerve impingement issue. And he's awesome. But there are other practitioners who are not necessarily awesome. So this is a warning about it can be expensive, and be sure you're working with a reputable provider. Okay, so if you don't feel that the tongue is an issue, then you keep working on other breastfeeding problems. Then they have a list down here of other things to think about that can cause trouble with breastfeeding, and I won't read them to you, but if mom has a low production for other reasons, the tongue may have nothing to do with it. So to keep that in mind, and if there's any other musculoskeletal thing going on, or the baby's just premature or sleepy, you got to remember that. And I felt that too, they really left out. Torticollis is so common, and if your head's held crooked, it's really hard to breastfeed well, and that needs to be addressed by a physical therapist, not a surgeon. Any facial asymmetry can point you towards more neuromuscular issues. Plain old high or low tone in either direction can interfere with breastfeeding, and you want to think twice about blaming the tongue. And if any of those things are present, then you want to find somebody, OTPT or an osteopath, to help address those problems rather than do a frenotomy and have it not help because it was the neuromuscular issues to start with. So what symptoms can a mother have in the presence of a restricted lingual frenulum that is source of the problem? There are often open wounds on the nipples, and they do often tend to be more of this off-centered, large, can be pretty deep crack on the tongue side. So here the baby's nose was up here, they come off, there's often a crease around here and then this wound down where the tongue is. Mom often describes she feels it's rough like a cat's tongue, and she can actually feel the tongue rubbing against her nipple with each suck. And usually you can see compression after feeding. It's really rare. I'd say it doesn't happen. A tongue tie is not the cause of your pain if there's no compression, whatever, um, or at least a wound, even if there's no compression, because they can't get enough of it in their mouth to cause compression. The other big one is poor breast emptying. So if the baby can't either get the breast in their mouth very far or hold it back very far or lift their tongue and drop it to create the suction, then mom's going to get gorged if it's happening very early. She's going to get plugged ducts and mastitis if it's happening later, and she will experience a decrease in production over time based on how poorly the baby's removing. She'll also, if you're doing self-efficacy scores, she will score poorly. What about the baby? Basically, the baby's also two buckets. They're either having trouble with latch or seal, or they're trouble getting milk out. So if they're having trouble with latching on or sealing, they can't latch, or they can't latch deeply, or they make a clicking sound when feeding, which isn't absolutely 100% always because of a tongue tie, but if the tongue is trying to reach the roof of the mouth and gets pulled back by the frenulum, you can hear a clicking, snapping sound when it's pulled away. If they can't create a good seal, if they're choking at the breast, and there's some evidence that maybe babies with tongue ties have more reflux. The theory is that they're swallowing more air because of their poor seal around the breast with the tongue. Poor removal can lead to frequent or nearly constant feedings, and that may not be apparent in the early days. It may take time as mom's production starts to go down. They can be very sleepy at the breast because they're not getting much. They can take a really long time to eat. They cannot gain well. They can start to be frustrated. So they let go and they try and get on better, and they let go and they try and get on better. And depending on their personality, they can be screaming on day 2 or week 2 that, hey, this isn't working for me very well. And some of them ultimately decide, I'm not going to get back on there because that's not working for me very well. Other things to think about are, is the baby positioned deeply enough to be doing well? And these are all just basic things. What's mom's milk production? Is the baby born too early and too sleepy? Do they have a recessed chin that we already mentioned? And submucosal cuff, I hadn't mentioned that that's a reason to have trouble holding on. That has nothing to do with your tongue. Are the nipples simply too big for the baby? So all things to think about before clipping a frenulum. So the bottom line is it's about form and function. What does the frenulum look like? What does the tongue movement look like? How stretchy is it? How much can the tongue move or not move? And what kind of a breast is the baby dealing with? Not all frenulums cause trouble, which is frustrating because it makes it hard. Is there good milk removal and no pain? Is there good weight gain? So whenever I have a frenulum, either there's a rough start in the beginning or it's a significant looking frenulum and the function appears impaired, but the baby's doing well, I really recommend doing weight checks every week or two until they're 2 or 3 months old, because I have been burned in the early days that you think they're doing well because mom's supply is so generous, and then they go to their 2 week check and they haven't gained since 3 weeks. So you don't want that to happen, and you can avoid a lot of pain and milk production issues by catching it early. Why do some really restrictive looking frenulums appear to do okay? And we think it probably has to do with difference in nipple size and shape, different breast tissue elasticity. Some breasts are easier to grasp and move around than others. It's a two-person dance. What about those lip frenulums? The point of this article is they looked at 100 newborns in California, and 100% of them had an identifiable lip frenulum. So pretty much every baby has one. So there is no reason to go lasering them all just because they have one. They also had trouble. The same person would look at the same baby twice and give it a different rating. So it wasn't very accurate. type 2s, or you might guess the middle of the road ones are the most common, not the really severe or the really mild ones. The medium ones are most common. And what are they? It turns out they are also a fold of mucosa with some connective tissue deep to it that can come into the fold a little bit or a lot, like with a tongue frenulum. Some are stretchier than others, and some are more mucosal. This is a study looking at the degree of the lip tie, how far down does it come? And there was no correlation with how severe it was, quote unquote, with their breastfeeding abilities. And one study looking at a questionnaire observational cohort. So they identified lip ties, they followed them over time, 66 babies with the most severe lip ties, followed for an average of 6 years, and found no difference in breastfeeding problems, speech problems, or tooth decay. So um, this one talked about, this was from a bunch of ENTs, or yeah, a group of ENTs saying we do not feel that clipping a frenulum under the lip based on the grading is at all recommended. It does not make sense. This is to acknowledge that there's a group of ENTs, I can't remember where they are, but they published a study where they looked at 316 babies that they are now doing the tongue first and then the lip. So they clipped um, all 316 babies' tongue ties to help with breastfeeding. 303 of them did much better with breastfeeding. 13 of them, they decided they should clip the lip as well. So they're saying we feel that there are some times when clipping the lip or lasering the lip can be helpful, but we only do it after the tongue because the vast majority of the time it's a tongue problem. This is just the American Academy of Pediatric Dentists statement that labial frenulums should be left alone. Maxillary frenulum is another name for that, that there's no reason to clip them in babies, and that if they're really restrictive and you think they're causing trouble with food sitting next to the front teeth, that you can work harder to make sure you're taking care of brushing those areas and not letting food collect. The argument that, well, these really bad lip ties often result in a diastema, or a space between the front teeth. Pediatric dentists and orthodontists agree that we don't want you taking that out because we like extra room before we do orthodontia, and you shouldn't take it out till you're ready to do orthodontics to bring those front teeth together. Okay, so is it ever justified to clip a lip tie? We don't have good research to guide me here, but we who do this for a living would recommend that it's reasonable to consider only if the upper lip cannot flange out to create a seal at the breast, and mother is having pain right where that upper lip meets the areola. I've seen that once or twice in 25 years where it's so restricted you cannot flange the lip out and it hurts right underneath it, and you can't fix it with latch help. If they can't create a seal because their upper lip won't relax, and it's not muscular, it's functional from the frenulum, then that's reasonable. And if they're older babies and they're starting to have trouble with decay, then it would be reason. And the dentist says, yeah, I think we should get rid of this, then perhaps it would be indicated, but not near as many as are being done right now. All right, so let's do a case and see if you're still awake. Laura is a 24-year-old who presents with her first baby who's now 7 days old. He was born at 37 weeks, 3 days, and is now 10% below birth weight. He has lost 2 ounces since his visit with his primary on day 4. So she's coming to you because he seemed to be nursing fine until 2 days ago when he started fighting the breast at some feedings. Latch has become uncomfortable in the last 2 days, and she also reports she started feeling engorged on day 4, about 3 days ago. On exam, he's vigorous and rooting. His suck exam is good and feels normal, even with gentle downward pressure on the chin. So I didn't mention that. When you're doing your suck exam and you're worried about the tongue, if you gently pull on the chin while they're sucking, if pulling down their chin causes their tongue to pull away from your finger, it's a sign that the tongue might be somewhat restricted. He does have a tight, thin type 3 lingual frenulum that you can't see until you go in with your gloved finger, and this picture is bad, but there it is right there, and it goes all the way back to the back, but it's so tight you really can't see it without going in to lift the tongue out of the way. Laura's breasts appear well developed with mild engorgement, and she latches him in the cradle hold to the nipple only and reports 4 out of 10 pain. What would you do now? All you lactation helper people. She's having pain with feeding, and he's only latching to the nipple, not the breast. 4 out of 10 pain. Have her express a small amount of milk to soften the breast. That's a great idea. If the breast seems too firm, a little reverse pressure softening, or express a little bit. Yep. We're going to basically help her latch more deeply, right? Yep. Show her a different position. Yep. Maybe lay her back. Great. Get on the latch deeper. Perfect. So you show her how to support her decut breast in the cross cradle hold with an asymmetric latch technique, which feels much better. And you show her how much more areola he's got in his mouth. So she practices that latch a few times, and you coach her in breast compressions when he gets sleepy. So if he's not swallowing anymore, let's squish on that breast. But he only removes 8 cc's from the right and 34 cc's from the left, and you have her pump afterwards, and she gets 2 ounces from the right and 3 ounces from the left. So what are you going to recommend as a plan for these guys? Should we jump in and clip his tongue tie? Somebody might. I don't think most people would. OMM. Yeah, that's not a bad idea. It never hurts. Never hurts to have him evaluated. Um, but he's 7 days old. He's well below birth weight. He's probably not as vigorous as he could be, so I'm not going to probably judge him on his overall abilities today. So there's several different ways you could do it, but I would recommend that she continues to offer the breast with compressions and switch nursing when he stops swallowing during the day, offering him at least an ounce of pumped milk in a paste bottle after daytime feedings, and then 2+ ounces at night, however much he seems to want, instead of breastfeeding, and then see him again in a few days. This was an actual case I used, and I didn't see him again for 5 days. So he was seeing his primary for a weight check tomorrow to make sure that this supplementation is going to start bringing the weight up, and then pump as needed for engorgement and bottles. Where did I come up with these numbers? I just wanted to throw this in. This is from, I didn't tell you, I work at a breastfeeding center called Milkworks in Lincoln and Omaha, Nebraska, and we developed this handout for parents about how much do babies eat based on the studies we have so far at different points in time. So on day 7, I'd be expecting him to take an ounce and a half or 2. He only took a little over, I can't remember what it was, about 40 cc's. On day 7, and he's well underweight. So I want him to get offered at least 2 at night and at least 1 during the day, and as much as he appears to want to take. Okay, so 5 days later, he's 12 days old now. He gained 9 ounces in 5 days. So that tells you, wow, he's maybe a little dehydrated. He's gained a lot. He's only 3 ounces below birth weight. He's taking about 10 ounces a day in the bottle, including 3 night feedings without breastfeeding. And she's now pumping 8 ounces at a time in the night times 3, or 14 ounces a day more than he's eating. So her production was slow to get started because of her gestational diabetes and hypertension, but whoa, it's really going now. She's having no more latch pain. She latches him deeply and easily. He took an ounce and a half from the right and an ounce from the left and appeared satisfied. So what are you going to do now? What do you recommend to these guys? Supposed to be back to birth weight in a couple days. He's only 3 ounces below, so he's caught up really well. Still getting a lot in the bottle, but now only at night. What would you do? He took 2.5 ounces here in the clinic at 12 days. That's decent. And he's gaining super great. So you could do several things here. You could gradually wean from the bottles, depending on mom's confidence. You might say, let's just breastfeed 24/7, and you just pump for comfort because you're making 14 ounces a day more than he's eating, and get back together in a few days. Commend them on how far they've come for sure. Offer more breast and less pumping. Perfect. And yes, ask mom what her goals are. Presumably, she would like to quit pumping. It's no fun, and she just wants to breastfeed. Although she is liking putting some milk in the freezer because everybody does. So at 16 days, he's gained an ounce a day, which is appropriate, and he's now 1 ounce above birth weight. He's sleeping 1 4-hour stretch at night, but getting 8 feedings in 24 hours. He's nursing about a half an hour at a time, but sometimes only taking one breast, haven't used any bottles at all. Laura's pumping twice a day after nursing for comfort, and she wants a little for the freezer, getting 2 ounces per side. And she's still pumping once or twice a day for comfort for less than an ounce. If he doesn't take the second side at a feeding, she needs to still relieve a little pressure. So he nurses on one side for you. He takes 60 cc's and falls asleep. He wakes up and looks at you and says, yeah, I don't want that other side. So what are you going to do now? When should you see them again? What would you tell them to do, and how soon do you want to see them again? They're
Probably see
exclusively
him the
breastfeeding.
sooner the better.
Sooner the better. Okay. Like tomorrow? No, you're not going
Sure.
to see them tomorrow. Oh, okay. Sure. I mean, it depends on your patient population and how hard it is for them to get to you and all, but yeah, I mean, more help is never bad. Following them closely is never wrong. It sounds like they're doing pretty okay, but I'm concerned he only took 60 here today, and she's still pumping a fair amount. And we have that posterior, that tight type 3 frenulum that could be impacting milk removal, and we want to make sure that over time he does okay. And how long would you follow them for? Say you see them tomorrow and he's doing great, and then you see him in a week and he's gaining well, and she's weaned from pumping completely and they're exclusively breastfeeding a week from now. Would you say, okay, you're good? Well, I wouldn't. Again, I would say any baby with a frenulum that appears concerning, and especially if they had a slow start in the beginning that it could have had an impact on, you want to weigh them every week or two once you think they're doing well, um, just to be sure, until they're 2 to 3. 3 months is rare. Usually you can tell by 2 months. It's usually 4, 5, 6 weeks that it starts to become obvious that they're not removing milk as well. But if it's happening slowly at home and nobody's weighing the baby, they get used to it and may not complain, and it can be a shock. So every week or two. Perfect. All right. I just wanted to run through the procedure quickly if you've never seen it. Most of us use a little tool called a groove director that isolates the frenulum and protects the floor of the bottom of the tongue from our scissors. Then you go in with your scissor and you make a little cut approximately right there, trying to avoid these ducts that come across, the saliva ducts that come across the floor of the mouth. Probably halfway between them and the base of the tongue is what I'm shooting for. And here's a good place to point out, no one has described the best way to do a frenotomy. Some people go closer down here, some people shoot for closer to the tongue. No agreed upon best way. So here is a different example of a baby's frenulum and where I'm going to snip it, and then we hold some gauze under the tongue while we take mom into breast or take the baby to mom to breastfeed. This isn't the same baby before and after. before and after. So here's the edge of the diamond-shaped wound. Here's the top. Here's the other end. You can't really see the bottom, but it's roughly somewhere there. So this was a very thin one. It opened into a very thin, shallow diamond. There's a half a drop of blood here. And you can see how much better the tongue can lift and cup than it could before. Baby crying, much different look to the lift of the tongue. A different one just to show you how different they can look. This one is an Eiffel Tower insertion, we call it. So it has 1, 2, 3 insertions below. Really doesn't make any difference to what you're doing because you're going to snip right here. And this is the same baby after, where again, you can see this little ditzel where it's released, and all of that thin mucosa has just kind of disappeared. Here's what it looks like a day or two later. For a week or two, depending on how deep the wound is, they have this little eschar or a white or yellowish white spot. Important parents know about it so they don't think it's infected. If they do laser, it looks more like this. Laser's nice because you can go slowly and there's usually no bleeding. Takes longer, which is negative from the baby standpoint, but nice from the practitioner standpoint to see what's going on. There are complications that are possible. So I'm not going to spend a ton of time on this. I just want to make sure you know that it's a procedure. It's a surgical procedure and bad things can happen. When I started doing them 25 years ago, this wasn't really recognized. It's like, oh, it's a little thing. We can just clip it. It's no big thing. But now that so many babies are being clipped all around the world, more complications are being described. So probably one of the worst ones is this baby right here is from this article about an acute Staph aureus wound infection after release. So it's hard to tell, but the whole floor of the mouth is swollen and red. This baby stopped eating, refused to eat, got septic. You can see their skin is all mottled. This is not normal. I've never seen it, knock on wood. I don't know anyone who's seen it. There's been this case or two reported. In New Zealand, where a lot of people breastfeed and a lot of good studies are done on breastfeeding, they reported 16 cases of complications, poor feeding because my mouth hurts being the most common, respiratory events like apnea or airway obstruction, next most common, pain, bleeding, weight loss, and 3 of the children had other things going on like heart disease that were causing their feeding difficulty, but they happened to have a frenulum and somebody decided to clip the frenulum when that wasn't the problem. Some of the kids bled enough to get anemic and some had excessive scarring. They were not that old, 1 to 3 months or less at the time of the procedure. I don't know who this was. At 206 days, they had a complication. Maybe excessive scarring was found. I don't know. 25% had more than one procedure, and one baby had 4 procedures. So to me, if a baby has 4 sternotomies, that's a management problem. You can maybe have 2 because the first person was scared and only did it halfway, and the back half was still causing trouble. So a second procedure, I do occasionally, but 4 should never happen. 75% of these babies were admitted to the hospital for 1 to 14 days. So it's a procedure and things can go wrong. The baby even died in Canada, and I don't know any of the details of this case because there's litigation involved and there hasn't been any more publicity than this, but a 4-week-old went in for a sternotomy and died in the office. Big controversy about, is it necessary to stretch the wound after the procedure so it doesn't scar back down? This was a group of ENT or pediatric surgeons in London, 600 babies less than 2 months. They massaged 2 times a day for 7 days, started 24 hours after the procedure, divided the babies in half. And they saw no difference in tongue function or breastfeeding efficacy if they stretched or didn't stretch, but they were quick to point out that only 43% of parents would do that to their baby. They wouldn't go in and push on a fresh wound because it was clearly uncomfortable for their child. And so even though they were told to do it, they admitted, yeah, we didn't actually do that. So we have no evidence. Stretching prior to the procedure, we have no evidence that would be helpful, and it doesn't make any sense. If you're talking about muscle tension, then maybe. But if you're talking about the frenulum, it is made from what it is made from, and especially if there's any fascia in it, you're not going to stretch it. And the thing that doctors say about, oh, it'll stretch as they get older, we really don't have any evidence for that either. When's it best to see them after frenotomy? We don't have consensus about this. 1 week is a reasonable time, and what I usually do to just look at the wound and make sure it's doing okay, but usually they're following up with their lactation people sooner than that. This particular group of ENTs were in the habit of looking at the wound at 2 weeks and deciding if it was too restricted, and then they would push on it with their finger trying to open it back up. They decided to start seeing them at 1 week and found it's a lot easier to pop the wound back open in a week if you see them in a week. But I, golly gee, I've been clipping tongue ties for 25 years and I've never seen them grow back or scar down or need revision because of scarring or lack of stretching. So I think this is a situation where babies are being revised and the tongue function was not the problem to start with, and the problems don't get better, so they just keep trying to make the tongue look better. I don't know. So about a week, I would say a lot of people would say is a good idea. What about other reasons to uh, do a frenotomy, like speech? I am guilty. I have done very tight anterior type 1 frenulums where it's clear, especially in Hispanic populations, where the dad says, I had a tongue tie and I couldn't roll my R's until I was 10 when they finally clipped it. Please clip my baby's tongue tie. When it looks like there's no way they're ever going to get their tip of their tongue to the roof of their mouth to make a T or an S sound, then it seems reasonable. But we do not have research to support that. Uh, until last year, we have this study about clipping average age patients of 4 years. So when you wait and see if a kid has trouble with articulation, if they have a frenulum under their tongue, clipping it can be helpful. But we don't know how to decide which babies are going to turn into those kids, right? So I would I would bet you that someday we will say, yes, you should clip them when they're little so that they can learn how to use their tongue to speak most correctly, but nobody has studied how to decide which babies those are and when to do it. What about sleep apnea? We have a little bit of evidence that in older children with sleep apnea, clipping their frenulum might be helpful. So again, how are we going to decide which babies are going to turn into those children with sleep apnea? Don't know that yet either, but it turns out maybe there's something to that. We are in just the early, this again was last year, just the early stages of looking at that. What about, oh, whoops, that's the same slide. I'm so sorry. I made a mistake. Oh, here. It's because I added this. This is back to those ear, nose, and throat people doing their statement. They said back in 2020, ankyloglossia absolutely does not cause sleep apnea. 8 out of 10 said, yes, that's true. Now we're starting to get some evidence maybe that's not true, but to be fair, they didn't know that yet. But they also address buccal ties, which are little folds of mucosal up above your gums, either above or below on the gums. And those are now getting lasered for breastfeeding issues. And we have absolutely no evidence that that is necessary nor helpful. So please do not endorse buccal tie release at this time. So our conclusions are tongue function should always be taken into consideration when considering a lingual frenotomy. Our knowledge gaps are great. We don't know, are there other reasons to do it? What is the best age to do it for any of these reasons? What is the best tool to use? Is laser better or scissors better? I didn't talk about that. There's a little evidence that laser causes more more feeding aversion afterwards, presumably from more thermal damage and pain. And there's evidence that there's more problems with bleeding after cold steel scissors because they're not cauterizing the tissue as they go. But those are the only two differences we've seen so far. Do we need other therapies such as body work? And I think, yeah, we probably do, but who should do that? And we don't have enough well-trained providers scattered around the world to be doing that. So we need to work on that. Aftercare of tongue tie release to prevent scarring, is that helpful or harmful? Again, we don't know for sure, but we don't have evidence it's helpful yet. When should you see them? When's the best idea to see them again? And does it affect speech and articulation later in life? And then here's all the stuff I took out. So if anybody's just really anally interested in wanting this list of other articles, please let me know. I gave you my email. I forgot to point out. Kathy@lacted.org is my iAble email.
Sure.
Interesting.
Do you mind to share your slides with
Yeah.
me, and then I'll
Mhm.
we'll share them with the group. That would be
Sure.
awesome.
Yeah.
As well as that handout that you have about milk volumes. I'm fascinated.
Oh, sure. Yeah. There's a brand new meta-analysis about that actually our handout says the average baby takes 24 ounces per day from 2 to 6 months, and there's a new worldwide study done that came out with 26 ounces. So it's still right in the ballpark. It's not 40. So yeah.
Normally, yeah.
Yeah. So darn it, I came all the way up to time, didn't I?